about pelvic pain today. Right, definition, types, common misconceptions. We're going to talk about the causes of pelvic pain, GYN and non-GYN related, and kind of what we do to diagnose and to treat it. All right. So first of all, what is considered pelvic pain? So it's discomfort, right, or a different level of discomfort or pain in the lower abdomen. It can be acute or chronic, so meaning it can be, varies in duration. So you could have had this pain for years, or it could be something that just started 2 hours ago. And it affects many women, especially during their reproductive years. And that, of course, is going to depend on the cause of the pain. Again, it can be constant, intermittent, or cyclical. Cyclical, typically, we mean with menstrual cycle. It can be worse with physical activity. The pain can be present or be worse with sex. Pain with menstrual menses, it could be with bowel movement or voiding. All right. Now, and this is, we're probably not going to cover every single cause of pelvic pain, so we're just focusing kind of on the most common causes. So acute versus chronic, right? Acute is something new or sudden. A lot of times acute pelvic pain, especially if it's severe, will bring the patient to the emergency room. It can vary in severity and again in duration. So it could last a few seconds or it could last for hours or days. Chronic, something that's been present for more than 6 months. And it doesn't have to be to the same extent for those 6 months, right? So it could come and go, or it can be worse or better, or it can be constant or cyclical. Now, as far as location, so to understand kind of where the pain is coming from, we just need to know kind of general anatomy, right? So this is your entire abdominal cavity. So if somebody says, well, I have pain here, could this be, from my ovaries? Well, if you look at the anatomy, that's not going to be, the ovaries are not going to be the cause of that pain, because geographically, the ovaries are way down here in the pelvis. So this is likely stomach area, right? So your stomach, reflux, things like that, heartburn will cause this type of pain, or also gallbladder. It's going to be more kind of in the right upper quadrant. Then you have intestines, all right? So the large intestine is sort of the wider intestine. It goes all the way down to the rectum down here, and then you got your small intestines, or the thinner caliber intestines. So those occupy the majority of your pelvis and your abdominal cavity. So most of the time, especially if the pain doesn't have any particular pattern, most of the time it's probably gastrointestinal, right? It's your intestines, maybe something you ate, could be gas pain. So sporadic sort of pain is usually intestinal. Then you have your appendix, all right? And then the uterus is way down here. So again, if you're having pain in your upper or mid-abdomen, unless your uterus is enlarged, it's probably not going to be of uterine cause. And then the bladder that sits right in front of the uterus. And again, large intestine kind of ends in the rectum, and it's all down in the lower pelvis. So infections typically lead to acute pain, right? So if you've had a pain for a year, you probably don't have an infection. So bladder pain or bladder infection will cause pelvic pain, remember? So because of where the bladder is located down here. And typically it also is going to have some urinary symptoms, right? Pain with voiding or frequent urination. And that's easily diagnosed with urine culture. PID, or pelvic inflammatory disease, so that's an infection of the uterus or in tubes and ovaries. Sometimes there's going to be actually an abscess or infection collection. And that also has associated signs and symptoms like high fever, elevated white blood cell count, which is going to be in your blood work. There's going to be severe pain, and there's going to be ultrasound findings. So if that type of pain brings you to the ER, specific imaging study or blood work will identify that infection. Appendicitis, again, CAT scan findings, and then elevated white blood cell count, fever, severe pain. Colitis, which is inflammation or infection in the bowel, in the intestine. Again, elevated white blood cell count. Diverticulitis is going to be somebody who has history of diverticulae, which are little outpouchings on your large intestine. And again, these are diagnosed with CT scan and blood work. So typically infection can be easily, identified. At least, if a white blood count is elevated, that tells us that there's an infection somewhere. And then typically imaging or other tests can identify the source. Kidney stones also is a common cause of acute pain, can be very severe, of course, and that's seen on the CAT scan. Ovarian cyst rupture or torsion. So rupture is a rupture of the ovarian cyst. Torsion is when the ovary and the cyst twist and cut off the blood supply. So that can be found on ultrasound findings. Ectopic pregnancy or miscarriage, also on ultrasound, and obviously a positive pregnancy test. But it could be something like constipation, right? So severe constipation where there's a lot of stool that's collected in the large intestine will cause distension of the large intestine. It can cause pretty severe pain, and that can be seen on the ultrasound findings or even just on an abdominal x-ray. Urinary retention, so if you're not able to empty your bladder, that can be found on imaging as well. And then, of course, some type of cancer or pelvic mass would be seen on imaging. So usually the acute causes, if it's a new onset pain that brings you to the ER, to your doctor, blood work and imaging, most of the time will identify the issue. Now, with chronic pain, it's a little bit more complicated because some of the chronic conditions don't show up on imaging, right? So again, starting with the bladder, painful bladder syndrome or interstitial cystitis will cause pelvic pain or painful urination, but your tests will be normal. So urine culture will be normal, bladder ultrasound or pelvic ultrasound will be normal. So you may have those symptoms, but the tests don't really tell us what it is. Endometriosis, same thing. It will cause pelvic pain, but not necessarily show up on any imaging. Pelvic adhesions or scar tissue also will cause pain and not show up on imaging. And then IBS, irritable bowel syndrome, again, doesn't show up on imaging. So it's mostly kind of diagnosis based on symptoms. And then there's some chronic conditions like inflammatory bowel disease, like Crohn's disease will cause pain, but that's diagnosed by a biopsy on colonoscopy. Fibroids are diagnosed with ultrasounds. Ovarian masses or pelvic masses or cysts diagnosed on ultrasounds. And then cancer, again, can lead to long-standing pain because it hasn't been diagnosed. But again, an imaging study will identify it. So pretty much, if you've had normal imaging, right, and whether your pain started 2 weeks ago or 2 years ago, and everything's been normal, you've ruled out a lot of things, right? So now you're most of the time kind of down to these 4 things. Now, kind of outside of that category is like musculoskeletal pain. So pain that's not coming from any of the internal organs, but more from the muscles or the ligaments or connective tissue. So I'm not including that in this discussion, but that's also something that needs to be ruled out. So diagnosis, again, I think I've covered the acute, right? So imaging, blood work, all those things. And then for chronic, also imaging. And then really these two I've kind of put in a box because endometriosis and pelvic adhesions, you really need laparoscopy to diagnose, and then you would treat it at the same time, right? So a lot of patients, for example, when they come in for a consultation for possible endometriosis or scar tissue, they want to know, well, if you do the laparoscopy and you see endometriosis, do you then do another surgery to remove it? And the answer is no, you do it all during the same surgery, right? So that's the benefit. Not only do you get to confirm that there's endometriosis or scar tissue, but you also treat it at the same time. So what is laparoscopy? So laparoscopy is a minimally invasive procedure to look inside the abdominal cavity, right? Because normally we just see the abdomen, we can't really see what's going on inside. And as I mentioned, with endometriosis and pelvic adhesions or scar tissue, you can't see those things. on imaging. So that's where the laparoscopy comes into play. So typically just two small incisions. It's an outpatient procedure, so you don't have to stay in the hospital. And it's a 3 to 5 day recovery, all right? And again, during the time of the surgery, if scar tissue is identified or if endometriosis is identified, it's removed at the same time. So for pelvic adhesions or scar tissue, when is someone at risk for having scar tissue? So prior surgery or infection. So that's part of the history, right? So if a patient comes to our practice and they say they have pelvic pain, we start asking them questions, what surgeries have you had? Have you had a prior infection? And it's all in trying to identify what could be the possible cause of the pain. So if I see someone with multiple prior C-sections or bowel surgery or fibroid removal surgery, and now they have pain, one of the causes could be scar tissue. And also it could be sort of the nature of the pain. So typically with scar tissue, the pain is not going to be cyclical. So it's not like if you're only having pain during your menstrual cycle, that's probably not just the scar tissue causing the pain. Scar tissue pain is usually constant. It may get worse with period, but there's going to be, some continuity of that pain because if the scar tissue is there, it's there throughout the month. It doesn't sort of come and go. So different prior infections or surgeries will cause scar tissue to form in different locations. So for example, pelvic infection or pelvic inflammatory disease can cause scar tissue formed to the fallopian tubes. And they can actually lead to hydrosalpinx, which is collection of fluid inside the fallopian tube, which can potentially cause pain. And it would also cause infertility. Prior C-sections will cause the bladder and the uterus scar tissue, and also the uterus can get attached to the abdominal wall. Prior myomectomy or fibroid removal surgery can cause small bowels to get stuck to the uterus or a large bowel to get stuck to the uterus. Prior bowel surgery can lead to bowel being stuck to the abdominal wall or loops of bowel get stuck together. So all of these things we're considering as we're talking to the patient where that scar tissue might be. So benefits of laparoscopy, of course, you can see where the scar tissue is, and then you can address it at the same time. And then you're also ruling out endometriosis, which can also cause pain, right? So when we're going in laparoscopically on the patient that has pelvic pain, we're looking for scar tissue and we're looking for endometriosis because allegedly we've ruled out other things prior with imaging and other evaluations. And then at the same time, we can check the fallopian tubes for patency, especially if it's someone who wants to get pregnant. And the benefit also, obviously, if you address the scar tissue, then you can stop taking pain medications or doing other non-surgical treatments that have not been effective. So this is an example of, patient with multiple prior C-sections where this is the top of the uterus and this is the abdominal wall and bladder, and there's connection, this thick sort of connection between, which shouldn't be there. There's another one, a thick band here, and that's the abdominal wall is here, and this is the uterus, so they're fused together and forming this bridge. Normally, the uterus should end here, and there should be space in between. And typically, the bladder is involved in that as well. This is omentum and bowel, so small bowel, and omentum is just a sort of a sheet of fat that hangs off the bowel. So those are stuck to the abdominal wall. All right. So these all can be as a result of C-sections. So typically more than one. It's unlikely to see this thick band like this or like this after one C-section, but sometimes we see patients with multiple prior C-sections, like 3 or 4 C-sections. So that would produce pelvic pain. Typically, this pain would be pretty constant and may get worse with period, but typically there would be some level of pain daily. So endometriosis, again, another condition that's diagnosed with laparoscopy, right? So what is endometriosis? It's a very common condition. So when abnormal tissue grows outside of the uterus and causes inflammation and pain. So in women with pain, infertility, or both, the frequency of endometriosis can be as much as 50% or even probably more. The endometrial cells that grow in the muscle of the uterus cause adenomyosis. So again, that's endometriosis of the muscle of the uterus. And then outside of the uterus is endometriosis. Sometimes it can grow in the bowel, in the bladder, even the upper abdomen, like the diaphragm, can be on the appendix. It's an estrogen-dependent condition, and so you're not going to see symptomatic endometriosis in someone who's 75 years old, right? So we're talking about reproductive age when the estrogen is being produced, and so endometriosis sort of thrives and causes issues. Common symptoms: pelvic pain, pain with intercourse, pain with bowel movements, pain with urination. Can mimic IBS symptoms or mimic painful bladder syndrome. Can cause just constant pelvic pain as well. The benefit of laparoscopy is to really identify the endometriosis, right? To confirm the diagnosis and then determine the severity. So that's very important because sometimes patients say, well, my OBGYN told me I probably have endometriosis just based on my symptoms, but they really discourage me from having laparoscopy because we already sort of know that it's probably endometriosis. What is the point of doing the laparoscopy? Because endometriosis can come back even if you remove it. So the point there is that yes, endometriosis can come back even though you remove it, but you really don't know what stage of endometriosis we're dealing with. And depending on the severity of the disease, our treatment approach is going to be very different, right? So even though endometriosis can come back in stage 1, just like it comes back in stage 4, you're going to manage it very differently. At the same time of the surgery, especially if we're talking about someone who desires fertility, and most endometriosis patients, because we're usually dealing with patients in their teens or 20s, they do desire future fertility. We want to check the uterine cavity and the fallopian tubes and the bladder. So we're checking everything else at the same time to kind of rule out other things. But also we want to determine their impact or the endometriosis impact on the fertility and really improve their fertility outcome, even if getting pregnant is not something they want to do right this minute. But the medical treatment after the surgery is going to differ depending on the stage of the disease. So this is an example of mild endometriosis, right? So this is normal anatomy, normal size uterus. You've got fallopian tubes, ovary. This is the left side, the right side here, with ovary hiding kind of behind the large intestine. It's a little bit dilated, but normal anatomy. But then the closer look reveals this endometriosis lesion here and here. And there's something over here as well. So this is mild stage 1 endometriosis, right? But so this patient has pelvic pain, worse with periods and infertility. So what we would do during laparoscopy, in addition to excising the endometriosis, right? So actually cutting it out and sending it to pathology for confirmation, we're going to check the fallopian tubes, make sure that they're open. We'll check the inside the uterine cavity and also check the bladder. All right. So, but otherwise, this is no scar tissue. Everything anatomically looks good. But the benefit is now we've confirmed the diagnosis of endometriosis. We've removed it, and we can reassure the patient that her prognosis in terms of fertility is very good. And so, if the patient is not trying to get pregnant at this moment, we would probably start, if they have not already been taking, we would start the patient on just like a birth control type of medication for this mild endometriosis. Now, this is same thing, same symptoms, chronic pelvic pain, worse during periods, infertility, but this is a totally different picture, right? So here's the uterus, here's the ovary, here's the fallopian tube, but it looks very different, right? So the other picture is sort of half of this, showing this part. Oops. So here you got the tube. You can't even see the end of the tube. It's over here. It's stuck to the uterus. All of this stuff is all endometriosis. So it just looks terrible. So this is stage 4 endometriosis. You've got rectum stuck to the back underneath the uterus here. So all the anatomy is very distorted. Things are stuck together. So this is going to be a completely different approach, right, after the surgery. First of all, the fertility prognosis is much worse on this patient. We would probably recommend IVF, which is in vitro fertilization. So the patient would be immediately referred to a fertility specialist. We would put the patient on suppression therapy, right? So instead of just giving them birth control pills, we would actually give them medication that would stop the hormone production temporarily to kind of help slow down the disease. So with this, the surgery is not going to be removing all the endometriosis because there's likely endometriosis in the uterus, the tubes, and the ovaries, right? It's more like you do as much cleanup as possible, then supplement with suppression therapy, and then you go to the fertility next. So non-surgical treatment, again, it's all focused on post-surgical treatment, right? So you're not going to treat something if you haven't even made the diagnosis of endometriosis and you have no idea if it's there or how severe it is. I don't recommend just starting on these medications because you don't really know what you're treating. I mean, it's fine to try things like birth control pills if you have painful periods, but if your symptoms have not improved, you need to go, on to determining the accurate diagnosis with surgery, and then you can figure out whether to continue the pill because allegedly post-surgery, now the pill is going to be much more effective because you've actually removed the disease. But if it's severe, you're going to need something like anti-hormone medications, right, to actually suppress or stop the hormone production. And again, to make a decision regarding fertility management. Do you want me to stop to answer questions or keep going?
We have only one question that came in the Q&A. Actually, this is a good time actually to talk about it. I have this person have had 3 surgeries for endometriosis. And even after surgery, I'm left with chronic pelvic pain. And the question is, if endometriosis was removed, what can be causing this chronic pain? Scar tissues, or can there be issues with the nerve?
Probably not issues with the nerve, but typically it's either scar tissue or what's left there. So if, let's say, you've had 3 surgeries for endometriosis, but you still have the uterus, tubes, and ovaries, there may be endometriosis in those structures. So sometimes we do a pelvic MRI to try to look for endometriosis in the uterus. Appendix could also be the source of the pain because you could have endometriosis in the appendix. So again, kind of thinking about what's left there, what structures can be a source of the pain. Bladder, obviously you're not going to remove the bladder, but bladder could be, chronic bladder syndrome. So if you've had 3 surgeries and it was always very, very mild endometriosis, it could be that, and especially if you're not getting relief from the surgery, you have to kind of shift gears and look for other causes of the pain, which could be, again, uterus with adenomyosis or bladder with interstitial cystitis. This is just, I mentioned evaluation of the uterine cavity, so this is just to kind of go a little bit further into that. So hysteroscopy typically is done at the time of the laparoscopy. So it's using that same camera approach, but now you're going inside the uterine cavity to make sure it's a normal cavity. It doesn't have any, like a small fibroid or a polyp. Fibroids and polyps typically are seen on the ultrasound, but you're just also biopsying the uterine lining to make sure that there's no issues there. The bladder, the painful bladder syndrome, so it's cystoscopy, which is, again, using the camera approach, but now you're looking inside the bladder, and it's done at the same time as the laparoscopy. And so with interstitial cystitis, which is the painful bladder syndrome, what we do is we over-distend the bladder, and then sometimes you'll see these petechial hemorrhages, so they're actually bleeding from these little blood vessels. And so if that's identified and that's consistent with patients' kind of clinical symptoms, because typically you don't have to see this to have interstitial cystitis. A lot of it is based on clinical findings, so meaning symptoms. So if there's symptoms of IC like overactive, bladder or painful urination, then diet modification can be helpful. So actually following the interstitial cystitis diet and avoiding certain bladder irritants, their medications, and then bladder installations where we actually fill the bladder with a cocktail of different medications to try to calm the bladder lining, which is inflamed. Other conditions that can cause pain are fibroids, right? So fibroids are very, very common. So the procedure that we do is the LAM procedure. It's a minimally invasive technique to remove the fibroids. So even with numerous fibroids, you don't have to have big open surgery. And so the small incision here, it's demonstrating the post LAM incision. Ovarian cysts, right? So we talked about torsion. So you can have a dermoid cyst or some other type of ovarian mass that will cause the twisting of the ovary and can cause pain. So that can be taken care of with a minimally invasive procedure, depending on the patient's age or what type of cyst it is. Sometimes we remove the entire ovary, but a lot of times the ovary can be preserved and only the cyst removed with just 2 small incisions. Now, example, why it's important to really be your own advocate and not to delay care is this patient. So she's 29 years old, longstanding history of pelvic pain, right? So chronic pain and painful periods. She was being treated with oral contraceptives. That's what OCP is for over 10 years. So this is pretty typical, right? So a teenager, right, has pain, and they're prescribed birth control pills because the pain is mostly menstrual, and so that goes on for years. But the pills are not really effective in controlling symptoms. So first thing we think about is endometriosis, right? And this is why you shouldn't treat endometriosis without doing laparoscopy, because you don't know how mild or severe it is. If it's mild, sure, that's fine, but you don't have a crystal ball, right? So if I knew ahead of time that somebody had mild endometriosis with just a couple of spots, then I would say you don't need surgery, you can just continue birth control pills. But typically patients that we see have already been on the pill, right? And the pill hasn't been effective. So they're looking for successful treatment. And so in this patient, we did laparoscopy. We actually found very severe endometriosis. I mean, almost every surface inside was covered with endometriosis, starting from the pelvis going all the way to the upper abdomen. So this is actually the liver and the gallbladder here and some bowel, and this is the diaphragm. So she has multiple lesions, and you can't see it on the picture, but it's all the way up here. So way up here with endometriosis, and then in the pelvis, everything was covered with endometriosis. Tubes, uterus, rectum, ovaries. Oh, I didn't put ovaries in here. Yeah, she had ovaries, bladder, appendix. So all the structures was very, very diffuse, so kind of scattered. So what we did was, and of course, a lot of scarring. So that's stage 4 endometriosis, where you have a lot of scar tissue and endometriosis spots. So there was a large endometriosis cyst on one of the ovaries. There was a lot of scarring. So she had surgery. Then she had to have 6 months of suppressive therapy, which is where she was sort of put into menopause with medications. And then she had another laparoscopy to remove any residual lesions, because there were so many lesions throughout abdomen and pelvis, we couldn't remove all of it on the first surgery. And so the follow-up with her was that she was pain-free after the second procedure. And then she was switched on to birth control, but she's require very close follow-up, probably monthly follow-up, because this endometriosis will definitely come back, but it's a matter of kind of retaining fertility and maintaining a good quality of life. All right, I think I've rambled on enough, although I kind of did it quickly.
Oh,
So we
that was
have
perfect. That was concise and perfect. It gives us a lot of time now to do Q&A. So this is your opportunity to ask any questions. I did jot down, someone sent a question in the Q&A, Dr. D. I left it in the chat box. So you can start with that question. And so keep your questions coming. We have plenty of time to do Q&A. So if you have any questions, go ahead and share them in the chat box, please.
All right, so the first question is, I had laparoscopic myomectomy a few years back to remove fibroids, and things got better, but then about a year after, I started experiencing new symptoms, especially during my cycle, mainly vomiting and pelvic pain. Pelvic pain usually starts immediately after bleeding stops and ends right after ovulation, but in total lasts about 10 days. I can't go without taking pain medications, but I don't think it's good for me to take this much pain medication every month. Could this be endo? Yes, so it could definitely be endometriosis because it's cyclical. I mean, some of it could be some scar tissue from the myomectomy, but again, typically scar tissue is not cyclical in nature. So I would say endometriosis would be at the top of my list. You know, definitely first to get an ultrasound, right, to see if there's any recurrent fibroids or anything that's obvious on the ultrasound, like an ovarian cyst. And then you would do laparoscopy to treat whatever is going on. So yeah, so endometriosis, question is, can endometriosis come back once it's removed during surgery? Yes. So it's estrogen dependent condition, meaning that hormone estrogen that's produced by the ovaries, that's what makes it grow. So as long as that estrogen is being produced, endometriosis can come back. You know, it's a what we call a chronic condition, and we do recommend continuous follow-up with the specialist to manage it. So given the success rates and benefits of UFE, including reduced scar tissue compared to myomectomy, how do you determine which option is more beneficial for a patient? Yeah, so we didn't go into sort of fibroid treatment, but UFE is another fibroid treatment procedure. It does not remove fibroids. So it sort of keeps everything in place, fibroids and uterus. It just cuts off the blood flow. It's not appropriate for patients who desire fertility. So that would be one thing. So if a patient has fibroids and wants to get pregnant, you would not offer them a UFE. And it's also not effective for very large fibroids. It does lead to scarring and inflammation because by cutting off the blood flow to the fibroid, it causes the fibroid to die, and that necrosis or death leads to inflammation and scar tissue. So I've done surgery on a uterus that had prior embolization, and there was quite a bit of scar tissue in there.
Dr. D, if I can just interject here.
Yeah.
I also want to mention, especially that you brought up UFE here, we have dedicated 1 hour webinar that we've done on kind of doing a deep dive on how effective UFE is in comparison to myomectomy and a dual port. And I highly encourage you to look into it because it's very helpful in helping you understand which one is effective for what. So
yes, exactly.
It's available also. I'll share that resource in my email that I will send as a follow-up. Okay, Dr. D.
Yeah, absolutely. Yeah, no, yeah, thanks for that. Yeah, but basically the point is that we want to, for each patient is different. They have different histories, they have different, you know, journeys and desires, and they have different fibroids and symptoms. So it's not kind of one size fits all. So you can, you know, that's why we change our discussions based on what the patient has and what the problem is. All right, is there a way to predict the stage of endometriosis by the length of time the person has had symptoms and or the cyclical pain level? That's a good question. That's a common question. So if you have, for example, severe pain, right? Does that mean you have severe endometriosis? Or if you're only having pain during your period, is it more likely to be mild? So not necessarily. I've definitely seen many cases where, because pain is subjective, and sometimes different people will sort of voice their symptoms differently. Somebody might kind of not intentionally but downplay what they're experiencing. They'll say, "Yeah, I'll have pain," and you would really, sort of, sometimes even after the surgery, I go back and say, "Well, do you have, even if they hadn't mentioned it before, like once you start kind of being a detective and saying, well, you must have had pain with this and that and that," and they say, "Oh, yes, yes, yes," but it didn't come up, prior to surgery. So sometimes, you find endometriosis to be much more severe than you expected, just based on the discussion. But typically, for example, if someone was, able to get pregnant pretty recently with no fertility treatments, and again, they might have only cyclical pain, but it's, maybe not all that severe. Yes, you're presuming that they have mild endometriosis, right? Because it's not to the point where it's impacted fertility. But you can never assume, and the best thing to do would be to do the laparoscopy. So I think, main thing is that yes, endometriosis can come back, but you still, if it's the type of pain that's bringing you to the doctor's office or bring you to the ER, and if it's been going on for a while, I think it's worth addressing. And there was also another question earlier, kind of about location of the pain, and I think I sort of covered it in terms of, if you're having pain that's kind of here and there and it doesn't have any particular pattern, typically GI is going to be your number one cause, or gastrointestinal, right? If it has a pattern that's centered around your period, then we're thinking of more of a GYN cause. But sometimes you just have to go down the list, right? So you see a gastroenterologist, they sort of do an evaluation, everything comes back normal, then maybe you do the laparoscopy to kind of rule in or out GYN cause.
So I
There's
have
another.
sorry, Q&A
Okay.
that came in just before this one. I just want to
Okay.
make sure, what exactly is birth control doing for endometriosis? Does it slow it down or just mask the pain symptoms?
So it's mostly masking the pain symptoms, but it's also, so with when you're not on birth control pill, and you're premenopausal, you're ovulating every month, and so around ovulation time, the estrogen levels go up, and that happens every month, right? So the estrogen levels are not the same throughout the month; they go up and they drop. If the pregnancy doesn't happen, period comes, and then the whole process starts all over again. So it's that up and down, or really the up, the spikes in estrogen levels is what the birth control pill is preventing. So there is going to be overall some suppression of the ovaries. Not that you're not going to be in menopause, the ovaries are still making hormones, but the ovaries are not producing so much estrogen. There's not that surge of estrogen that you would have off the pill. So it is helpful for endometriosis. And also just, masking the symptoms as well. So another one, I've had pain for more than 11 years, which has been described as pelvic pain. I did several tests and examinations and full body scans with no clear solution. One consultant said that I did not have endometriosis, while others thought I did. As a last resort, I did the diagnostic laparoscopy, but only scarring and cysts were found. While I'm happy it's not endometriosis, I still don't know what is causing the pain. Scarring, yeah, I mean, it depends on how much scar tissue was found, and I'm assuming it was all taken care of. And if the pain still continued, that probably, if it was mild scar tissue, that probably wasn't causing the pain at all in the first place. So yes, I agree. So now you're still sort of not knowing what's causing the pain. I would say bladder, evaluation would be helpful to make sure it's not painful bladder syndrome. If it's located on one side or the other, musculoskeletal cause. So sometimes patients will have what's called labral tear. So it's a hip joint tear that will cause one-sided pelvic pain. So that may need to be ruled out, especially if it's a pain that's on one side. So now, if everything's been ruled out and there's still no clear cause of the pain, then you kind of move on to treatment. So pelvic floor therapy sometimes can be helpful for pelvic pain, especially if there's no clear cause, and it can be helpful in relieving that pain. So I think if you talk to, now another important thing is who did the laparoscopy, whether any biopsies were taken, if there were pictures, to make sure that more subtle lesions were not missed. So that's another important point. So probably seeing a specialist is going to be important. Another question is, my pain is around my groin where my legs connect. So yeah, so that could be musculoskeletal. So that could be the labral tear if it's on one side. But even on both, presumably, I guess if you could have bilateral labral tears, right, on both sides. Pain is off and on, but it's more intense around ovulation. I feel like doctor is not listening to what question can I ask. Yeah, I mean, if it's cyclical pain, so again, if it's cyclical pain, most likely it's GYN, right? So if the pain is worse during a certain time of your cycle, and if it's been going on for a while, and again, yeah, it's on both sides. So it could be endometriosis. I mean, it shouldn't be, so ovulation pain shouldn't be painful, right? So some people will feel that they're ovulating, but to describe it as pain, typically that's not normal. So if you are feeling pain in the pelvis that's cyclical around ovulation, I think laparoscopy may be in order to check for endometriosis. And also remember that if you're on a birth control pill, you're really not ovulating. So even if you're feeling pain at a certain time of the month, you're not ovulating. So it's definitely not ovulation pain. All right.
So we have one question that came in through the Q&A. Is hysteroscopy painful, and are you able to undergo the procedure under sedation?
So if you're just getting hysteroscopy, so if you're not doing laparoscopy at all, so if you're not going inside the abdomen and you're just looking inside the uterus, that can be done under sedation. Yeah, I don't typically like to do any of the procedures without anesthesia. So sometimes you can do cystoscopy. So anything, if you're entering the abdomen from here, that requires anesthesia. If you're going through the vagina, so through an orifice that's already there, so vagina or bladder inside the uterus, so that can be done without anesthesia, but it can be very uncomfortable and can limit visualization, so how much you can see. So typically we recommend sedation for those procedures.
Right, I think we've gone through all the questions. If there are any more questions that you have that we weren't able to address, we do have a few minutes. If not, I'm gonna go ahead and start wrapping up. Thank you all so much for joining us this afternoon, and thank you so much, Dr. Danilyants, for taking the time to put this presentation and for addressing all the questions that came in. If, like I said, we didn't get to answer any of the questions you sent us via email, we'll make sure that we send you a response. Otherwise, thank you so much. I'll be sending the resources, like I mentioned at the beginning of the webinar, via email within the next 24 to 48 hours. The recording would be available in about 48 hours. What I would say is that please take a moment right now to complete a brief evaluation survey. This really helps us improve our program and just tells us what to emphasize, what not to emphasize in the future programming. So take a moment. It should take maybe a minute or so to complete the survey. And also, if you want to schedule a consultation, I have shared a link in above for consultation. I'll also share that information in my follow-up. And as a reminder, if you're a healthcare professional, I see a couple of you who've joined us who are veterans of our program that require a certificate. You do have to stay for the whole entirety of the program to be able to get those certificates, as well as complete the evaluation form that is mandatory for healthcare professionals. Okay, thank you so much for joining us, and I will stay on to give you an opportunity to complete that survey. Dr. D, thank you, and have a good afternoon.
Thanks.
Bye.
Thank you. Bye-bye.
Oh, the evaluation, Angela, you might have to copy and paste it. Then let me make sure that it is working, actually. Okay, let's try this one more time. Let's see. Try this one more time. We'll figure this out. Let's. Thank you so much, everyone. I hope you enjoy the rest of your day. I'll go ahead and sign off now. Angela, I hope you were able to access the link. If not, I'll be sure to send it in my email. Thanks, everyone. Have a good one. Okay, great.